The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar today will discuss computerized cognitive training, brain games, and brain training. My name is Christine Daly, Program Manager here at the American Brain Tumor Association. I'm delighted to introduce our speaker today, Dr. Heather Conklin. Dr. Conklin is a pediatric neuropsychologist at St. Jude Children's Research Hospital, where she is engaged in clinical research, provision of clinical care, and training of future psychologists, all with the goal of improving cognitive outcomes of children who have been treated for cancer. Thank you for joining us, Dr. Conklin. You may now begin your presentation.
Thank you so much for that introduction. I'm very much looking forward to giving this talk. Thank you all who have decided to join us today. So as mentioned, I'm Dr. Conklin. Today I'm going to be talking about computerized cognitive training, brain games, and brain training. I have no financial disclosures. So I believe most of you are aware that brain tumor survivors are at significant risk for cognitive deficits secondary to both disease factors such as mass effect of the tumor itself or hydrocephalus and treatment-related factors including surgical interventions, chemotherapy, and radiation therapy. Children, who I primarily work with, are at particular risk given their developing nervous system. These deficits, which we refer to as cognitive late effects, are prevalent and can be associated with a reduced quality of life. Sorry, just a second, technical problem. Okay, I think we're all right. Okay, so these deficits can be prevalent and they can also be associated with a reduced quality of life, which could include high unemployment rates as well as a decreased likelihood. Sorry, I'm getting text that there's a technical problem. Hold on one second, let me see. The slides are moving on my screen, which is being viewed. All right, I'm back. Sorry. Sorry about that technical problem. Let me see if I can figure out where we were. Okay, so as we were discussing, brain tumor survivors can be at risk for cognitive problems, and these can be secondary to both disease-related factors such as tumor mass effect or hydrocephalus, as well as treatment-related factors including surgical interventions, chemotherapy, and radiation therapy. Children with whom I primarily work are at particular risk given their developing nervous system. These deficits, which we refer to as cognitive late effects, are prevalent and can be associated with a reduced quality of life, including high unemployment rates as well as a decreased likelihood of independent living. The good news is that survival rates have improved significantly in recent years, and given this, there's been increased efforts to try and optimize long-term cognitive outcomes so that individuals can have the best possible quality of life. For children, longitudinal studies have most consistently shown declines on global cognitive measures, such as measures of intellectual functioning like IQ or academic skills like reading and math. And these declines most likely reflect a decreased rate of learning compared to peers, rather than a loss of previously learned knowledge. So for example, children will continue to learn over time, but the gaps will get larger between them and their peers. Sorry, there are technical issues. I'm not sure why we're having problems. Okay. Okay, I think we're back in action. So for children, as I was saying, longitudinal studies have most revealed problems with IQ as well as problems with academics, and that they continue to learn skills, but just at a slower rate than their healthy peers, such that that gap between them and their peers over time gets larger in those cognitive skills. We also know that there are certain factors that have emerged in the literature that show risk for cognitive deficits, which include a younger age at treatment, longer time since treatment, and higher treatment intensity, in particular radiation dose and volume. Also female gender and complicating medical factors such as experiencing a stroke or meningitis are things that also place individuals at greater risk for cognitive problems. So central nervous system directed cancer therapies, these would include things like intrathecal chemotherapy and radiation therapy, are well-established causes of changes in cerebral white matter, or what we call myelin. And there's accumulating evidence to suggest that reductions in the cerebral white matter is what accounts for the significant proportion of this IQ decline that we sometimes see in brain tumor survivors. And this treatment-induced white matter provides a context for understanding factors that place children at greatest risk. For example, it's now been shown that the volume of normal appearing white matter in the brain accounts for 70% of the association between the age at which a child receives radiation therapy and their IQ after controlling for time since radiation. Further, those gender differences we see with females being at greater risk for cognitive problems can be explained by differences between males and females in myelination, with males having a later peak. And this might explain that female vulnerability. Historically, there's been an over-reliance on global cognitive outcome measures in the existing literature, and greater specification of cognitive impairments is really needed for us to isolate what neural pathways are vulnerable, as well as us to move towards developing targeted interventions. More recently, findings suggest that impairments in attention, working memory, and processing speed may be more proximal contributors to global decline. So it's specifically these areas of attention, working memory, and processing speed that are underlying the more global declines. And working memory is a term we use to mean the real short, active form of short-term memory. So a common example would be rehearsing a phone number over and over again in your head so as to be able to deliver it, dial it without having to write it down. These emerging areas of deficit in terms of attention, working memory, and processing speed are informative, as we know that nearly half of age-related improvements in IQ can be attributed to developmental improvements in working memory and processing speed. It's important to realize that even if we fully optimize treatment, there remains risk for cognitive deficits related to the mass effect of the tumor itself. Further, with certain treatments, such as surgery or radiation therapy, we are simply going to reach a physical plateau in our ability to limit treatment while maintaining high survival rates. Thus, it's really important that we move towards developing interventions to lessen the late effects of disease and treatment. Yet, there have been relatively few attempts to develop interventions for brain tumor survivors. Some medications, including stimulant medications like Ritalin or Adderall, have shown improvements in attention and social skills, but are not appropriate for all individuals given medical contraindications such as individuals who have poorly controlled seizures or patient preferences. Some patients or parents simply prefer not to take a stimulant medication. We also know that there are therapists delivered cognitive remediation where you work one-on-one with a therapist that have shown cognitive improvements, particularly in things like metacognitive skills, but this requires a large time investment for modest benefits. And now there are new studies showing that there are even benefits of aerobic exercise or physical exercise, but we have a lot of work to do still to figure out how to get people to be adherent or to stick with exercise routines, as well as to identify what type of physical exercise and how much of exercise is needed in order for there to be cognitive gains. So today, we're going to largely be focusing on the area of computerized cognitive training that has really offered promising results. I'm going to pause for 1 second just to make sure we're doing okay with the slides. Okay, so what is computerized cognitive training? This refers to a group of computer software packages that are designed to exercise specified cognitive processes. Most of these computer programs rest on the principle of mass practice. What this means is that we have you repeat similar exercises over and over across multiple sessions. And it's really important with computerized cognitive training that the difficulty of the task be graded. And that means that the difficulty is going to get harder as an individual demonstrates success with the task. And many of these programs require some level of coaching by a trained professional. And this individual would do things like providing feedback, as well as assisting in maintaining motivation for participants. Computerized cognitive training has resulted in significantly improved cognitive functioning in a number of other conditions that are associated with cognitive deficits. This includes individuals with traumatic brain injuries, individuals with mild cognitive impairment or dementia, and individuals with schizophrenia. Computerized cognitive training has also been shown to be associated with brain-based changes, things that we can see on functional neuroimaging that include increases in activity in certain areas of the brain, as well as increases in connectivity between different brain areas, and changes in neurotransmitter function. And so what this means to us is not only are we seeing improvements in behavior that shows cognitive gains, but also brain-based changes that are occurring with these computerized programs. So Captain's Log is a computerized training program that's been around since the 1980s. It covers a wide skill set, including attention, working memory, visual motor, and problem-solving skills. I was able to locate published studies with a range of population that include individuals with HIV, cerebral malaria, ADHD, traumatic brain injury, dementia, and schizophrenia. And Christy Hardy and her colleagues have published a pilot study with 9 childhood leukemia and brain tumor survivors that demonstrate both feasibility or the ability to use this program, as well as acceptability by parents and the patients themselves. And also it suggested that there were some attention benefits when using this cognitive program. However, these investigators have subsequently moved away from using this particular program because the user interface is rather simplistic relative to modern graphics that led to some boredom and non-compliance. Also, there was a lack of suggested dose, so how many sessions should individuals be doing to get cognitive gains, and there was difficulty in standardizing the administration given the large number of potential tasks available in this program. So this brings me to COGMED. This is a newer software program that was developed specifically to train working memory skills, and as we discussed, working memory seems to be an area of struggle for many brain tumor survivors. COGMED was developed by neuroscientists and game developers at the Karolinska Institute, which is in Stockholm. It has 3 age-based versions that span a large age range. So there's JM for individuals 4 to 6 years of age, RM for individuals 7 to 18 years of age, and then QM for adults. It consists of sessions that are typically 30 to 45 minutes in length that are completed each weekday for 5 weeks. And the child or adult is guided through 8 rotating exercises daily. So each day you have 8 different exercises that are pulled from a larger group of exercises, and they train both visual spatial types of working memory skills as well as verbal working memory abilities. Importantly, as the ability improves, these exercises become more difficult. Again, it's important to have that graded difficulty. And compliance and performance can be tracked over the internet. So coaches can watch your performance remotely and then provide feedback through telephone-based coaching sessions where you can troubleshoot problems as well as do things to maintain motivation with the program. So pictured here is an asteroids task. This is one of the tasks in the child version, where each of these asteroids is going to light up in a random order as they're moving around in space. And the child has to remember them and their location, as well as the order in which they lit up in order to click on them. So this is an example of a visual spatial working memory task that can be used. I'm going to take a second now to go out to this site so that I can show you some of the specific tasks that are available in CogMed. Just bear with me. I'm picking the school age to young adult version, the RM version. And here I'm going to go ahead and pick a couple tasks to show you. So this is a robot-based theme, CogMed, for the school age version, where the child can see this panel each day. And then different exercises will be selected for them each day, which appear here on the screen. And the child can pick the order in which they complete them. So I'm going to show you one of the favorite childhood tasks here so you can get a feel for one of the spatial working memory tasks. This one is called Spacewhack. So
In these craters, there are little monsters that you must hit on the head. Before they come out, they let out a little cloud of gas. When they show up, splash them in the order that the gas appeared.
Okay, so I'm going to go ahead and show you how this task works. I saw the smoke there, and now it's going to let me respond. And then it gives some positive feedback for how you're doing. I'll show you one more so you can get a feel for this task. All right, and then if you keep going, you see on the right side here, there's a bar that shows you the difficulty level that you're performing at. So right now I'm at a 3, and as it gets more difficult, that bar will move up to serve as a visual reminder of performance for the child participating in the task. So here you'll see now it's going to get a little more difficult with 3 locations. And it would keep increasing in difficulty like that until the child got to the point at which they were right half of the time. So it's really challenging those working memory skills. I'm going to cancel out of this task, and I'm going to show you a working memory test that's more verbal than visual in nature. This one is called the input module.
Now I'm going to read out some numbers. Remember the order. 5, 2, 6. Then it's your turn to answer. Click on the buttons in the reverse order. In other words, the order but backwards. The numbers were 5, 2, and 6. So first you'll click on 6, then 2, and finally 5, like this. Okay, go ahead and try it.
So I'm going to go ahead and try myself. And here you can see it's numbers, and you're having to rearrange them backwards, so it's tapping into what we call verbal working memory.
1, 7.
Okay, so I have to do them backwards.
Good.
And you get some feedback. If you keep going, it will continue to get more difficult.
9. 9. 1, 9.
Okay, I think you have a feel for it. You can see it will continue to get more and more difficult with longer strings of numbers to be remembered with this bar going up on the side, and it will get you to the point that you're training at about 50% accuracy, again, to be really challenging. I'm going to cancel out of that task. I'm going to show you one more. Let's see, maybe 2 more. These tend to be interesting. Here's one that's more visual.
Some of the lamps on this panel will light up. Remember the order. Then it's time to enter the answer by clicking the lamps in the same order. I'll show you how. Done. Now it's your turn.
Okay, I'll show you once how I would do it.
Yeah!
Okay, so it's got feedback again that's tailored to more of a child audience. Okay, I'm going to cancel out that. I'll show you one of the most challenging of these tasks.
Here are some lamps going round in a circle. Some of the lamps will light up in a particular order. As the lamps will be moving, you have to keep track of where they have gone. Then it's time to enter the answer by clicking the lamps in the same order. I'll show you how. Done. Now it's your turn.
Okay, I'll see if I can do it once. This is a hard one. Okay.
Yes!
All right. So I think you all have a feel now for the nature of the school age version. I'm going to quit out of that and go ahead and exit out of this program and bring back our slides. Okay. All right. So now you have a feel for what one of these computerized programs look like. That one, again, is called COGMED. And there's been quite a bit of emerging research that's out there to support COGMED with different populations. Specifically, there's more than 60 peer-reviewed published studies at this time point. And what we've learned is that from studies that are called randomized control trials, so this is sort of the highest test of a study. This is when you sort of flip a coin and randomly assign some of the participants to the COGMED intervention and some to a control condition where they're not training, and then compare their outcomes. When those studies have been done, we've seen that individuals who do the COGMED intervention will have improved working memory and executive functions, particularly in children who have ADHD or children who are healthy but who have working memory problems, and in adults who are stroke survivors. There's also some evidence to suggest that benefits from COGMED training will be maintained 6 months after completing training, so some maintenance over time. And there's findings from a couple different functional MRI studies in healthy adults that show that there's, again, actually changes at the brain level. So if you look pre to post COGMED training, you can see areas of increased activation in different frontal and parietal areas of the brain. So again, suggestive of some sort of cortical plasticity, or the ability to change not just behavior, but the functioning and activity at the brain level. So Christy Hardy and her collaborators at Duke conducted a trial to look at how feasible it was to use COGMED in children who were cancer survivors and how acceptable it was for them and their parents. They enrolled 20 participants, with 13 who they randomly, or the flip of a coin, assigned to the COGMED intervention, and then 7 were assigned to a non-adaptive condition. So it looked similar to COGMED, but it did not get more difficult, which is a really important element. And what they found was that the acceptance rate was really high. Everyone agreed to participate, and that 85% of the participants were compliant with training. So they completed at least 20 of the 25 recommended sessions. And there was a high rate of satisfaction, with parents reporting that the majority of their children enjoyed the training. Here you can see some graphs from the outcomes of this study. And in the top graph, they were looking at working memory performance of the child, and that they could see that there was more improvement here from baseline to just after testing in the group that had the COGMED intervention relative to the group whose task did not get more difficult. And there was a trend for those benefits to be upheld at the 3-month follow-up. And when they looked at parent report, the group that got the COGMED intervention had parents report more of a reduction in learning problems that their child was experiencing. However, those benefits in this study were not maintained 3 months later. So these findings were very helpful in that they showed that families were interested in this intervention and would comply and complete many of the training sessions. However, it wasn't enough participants in this study to really look at how well this would work over time, and they did not include neuroimaging to look at what was going on at the brain level. So this brings us to a study that we conducted here at St. Jude called COGTRN. This is a study that was funded by the American Cancer Society. And what we did was we enrolled participants who were between 8 and 16 years of age. All of them had received treatment targeting the central nervous system for a brain tumor or acute lymphoblastic leukemia. They were all off treatment for at least 1 year without evidence of disease recurrence. They had English as a primary language, and we also screened children to make sure that they were in fact having working memory problems before enrolling them. Of note, we excluded patients who had a brain injury or disease separate from their brain tumor or leukemia, or children who had a pre-existing diagnosis of ADHD or attention deficit hyperactivity disorder. We also excluded individuals who had taken psychotropic medications like a stimulant medication within 2 weeks of having enrolled, or individuals who had significant motor, sensory, or psychological conditions that would make it difficult for them to participate in our assessment or intervention. So here is a concert diagram that just shows what happened with our study. I'll walk you through it briefly. We enrolled we screened 128 children, and of them 80, which is 63%, were identified as having working memory problems. So again, showing that working memory problems is a pretty frequent problem in this survivorship population. We randomized 68 of them, 34 got the COGMED intervention, and 34 were just on a waitlist control. And of those 34, 30, which is 88%, completed at least 20 of the 25 recommended sessions. So again, people were very willing to complete this intervention. And all of them returned for immediate post and 6-month post follow-up evaluation. And I should note that individuals that were randomized to this waitlist control group were then offered COGMED intervention as they came off study. Okay, so what did we find? Here are demographics for our study sample. And what we can see here is that our intervention group that got COGMED and our control group that did not were balanced in terms of gender and race, their age of participation, their age of diagnosis, and time since treatment. We can see that on average, individuals were 12 years of age, and that there was a trend for the intervention group to have a slightly higher IQ at baseline, but it was not significant. Here, when we look at the intervention control group, we can see that they were balanced with respect to diagnosis as well as treatment exposure. So about 2/3 of the children here in this blue section of the pie chart had a diagnosis of leukemia, whereas the remainder had a diagnosis of a brain tumor. And their treatment exposure was consistent with that, with about 2/3 having chemotherapy only and the other third having received cranial irradiation therapy. We were interested in seeing how often individuals have the computer skills they need to complete this kind of intervention. We did find that more than 90% of the families owned a home computer and had an internet connection that would allow them to participate. However, we provided laptops or internet to those families if it was requested. Presented here are results of a computer use survey we gave. It asked things about general use of computer, installing software, ability to connect to the internet. What we can see in this circled area here is that on average, families indicated that they were comfortable or very comfortable in performing these computer activities. And for these key skills here in red, these are ones that were particularly needed for the intervention. Comfort was upwards of 90% for the entire sample. We also had a parent satisfaction survey that was completed at the end of the COGMED training, and you can see here that on average, people felt neutral to more positive at the completion of the intervention. You can also see that 69% down here felt that their particular child had benefited from participating in this study, and 93% said that they would recommend this intervention to other parents. So here are the results displayed here. I'll walk you through. Basically, we have change scores here for the group getting COGMED. This is how they changed from baseline to immediately after completing their COGMED on different measures. And then the second column here is the change score for the control group. And we can see that most of these changes are significant, which just means that the group in the intervention group that received COGMED had significantly more improvements than the control group across a number of skills that included attention, working memory, and processing speed. And we also found that parents reported greater reduction in signs of inattention or executive dysfunction. It is important for us to also look further out in time. So these graphs follow them out 6 months after completing their training. And we can see for 2 different performance measures, this is a visual working memory measure, this is a verbal working memory measure, that the group getting the intervention here, who took part in COGMED, showed significantly greater gains during the training period, and that those gains were maintained 6 months later. So neither group changed that 6 months, and the intervention group receiving COGMED was still performing significantly better at 6 months. We see the same exact pattern here for the intervention group with respect to verbal working memory. When we looked at parent reports, we could see that there was a significant reduction in parent reports of executive functioning problems, that these were maintained over 6 months, and there was a trend for there to still be differences between the two groups at 6 months, and the same pattern for parent report of inattention. Okay, I'm going to briefly walk you through this slide. This was imaging that we did as part of this study. The child would be in an MRI setting, and they'd be looking at a screen where they saw sort of this 4x4 dot matrix, and one of the circles would light up. The screen would change, another circle would be lit. The screen would change, and another one would be lit. And so they had to learn a 5-dot sequence here, and then it was their turn to click where those spatial locations were. So it's a visual spatial working memory task. And down here is what we saw when we looked pre to post training and combined those. Basically, what we just wanted to make a point of here is that we were seeing activation in the brain in sort of frontal and parietal regions, which we know are important for completing working memory tasks. More importantly, what we saw is these areas in green here. What those show are areas that decreased in activation from prior to doing the COGMED intervention to after. And we can see that those areas are largely in sort of this left frontal area of the brain. And so what we think this means is that individuals became more efficient at completing this working memory task after they completed training. And because it was a spatial task where they had to just remember a spatial location, they no longer needed more of these left or language-focused brain areas. So they were no longer using sort of crutches of using verbal ways of walking through the task, such as it's the upper left square, it's the middle square, it's the lower square, but instead could rely more on their spatial working memory, which is the pattern we see more with healthy individuals. We also saw that there were some brain areas, such as these areas here in purple, that if we looked at activation in those areas before completing COGMED, it would predict for us who was most likely to benefit from COGMED training. So with the goal of eventually being able to hand select interventions for particular patients or survivors. Okay, a few more studies to review. Kessler and her colleagues, they used a different web-based computerized program. This program is also commercially available, and it's called Lumosity. They conducted a single-arm pilot trial, and their training consisted of 40 sessions. So it was 8 weeks with 5 sessions per week, and each session lasted 20 minutes. And they were looking at cognitive flexibility, attention, and working memory. They enrolled 23 participants, and 19, or 83%, completed their curriculum. So again, a very high rate of adherence or completion. And they found that those individuals completing Lumosity had improvements in processing speed, cognitive flexibility, visual and verbal memory. They did not find significant improvement in attention or working memory, but they did find changes on fMRI. So again, brain-based changes associated with training. So overall, these findings were really encouraging with respect to Lumosity, but because there was no control group, it sort of limits how much we can say about these findings, because there's the potential that there was just practice effects for the group receiving the intervention. Kessler and her colleagues also completed another study using the same Lumosity program, but this time with adult breast cancer survivors. These participants on average were 55 years of age. Sorry, I'm making sure we're on the right slide. Yep, were 55 years of age, and they were on average 6 years out from having completed cancer-directed treatment. Half of them were randomized to Lumosity and the other half to a control group. There's a very high completion rate with 95% completing the program. Again, this seems to be something individuals are willing to do. And those participants who completed the intervention showed improvements in cognitive flexibility, verbal fluency, processing speed, and they reported better executive functioning. That included things like better planning and organization. They also showed trends for improvement in verbal memory, which is sort of a more downstream skill, a less related skill to what the computer program was training. But again, found no changes in working memory, which they think has to do with how they were assessing working memory. So this again was very encouraging. but they did not follow these survivors longer to see how well the benefits were maintained. So Gehring and colleagues, these are individuals conducting research in the Netherlands. They completed a randomized control trial that used a multifaceted cognitive rehabilitation program, some of which include computer-based training specifically to train attention, and others which was teaching compensatory skills or ways to sort of get around problems you might be having with attention, memory, and executive functions. These were all adult survivors who had had a low-grade or anaplastic glioma. They were on average 55 years of age and 6 years out from completion of their cancer-directed treatment. 70 of them were randomized to intervention and 70 to a control group. And again, there was a very high completion rate with 94% completing their 6 weeks of individual 2-hour sessions with home-based computerized exercises. They showed that participants who completed this intervention had improvements in their own report of cognitive functioning immediately after training, as well as significant improvements on measures of attention and memory and mental fatigue that lasted 6 months after completing training. Yang and colleagues conducted another randomized trial, this time using a different computerized cognitive training program, and they combined it with virtual reality for some of the participants. So virtual reality, I think people know, are programs that are real-time and three-dimensional environments, so they make participants feel like they're really performing in a real-world situation. So for example, performing as a soccer goalkeeper with soccer balls being kicked at you. The participants were all adult brain tumor survivors who were at least 20 years of age. They were participating in a hospital-based rehabilitation program. They either were randomly assigned to have 4 weeks of just daily computerized cognitive training, or they were randomized to receive 4 weeks of that training that also worked in the virtual reality piece. Interestingly, both groups showed improvements in auditory and visual attention, visual and verbal learning, but the virtual reality group showed greater improvement in auditory or visual attention and auditory and visual working memory. So these authors felt like virtual reality programs may serve to further enhance computerized cognitive training, leading to more benefits. So Van Ah and colleagues, they conducted a 3-group randomized study to look at a memory-specific training in comparison to processing speed-specific training, and then in comparison to a control group. I include this study today because the processing speed training involved a commercially available program called Insight. In contrast, the memory training program was all in-person group training in teaching how to use memory strategies. So these participants were all breast cancer survivors who had cognitive complaints that were significant enough that they were impacting their daily life. Each group contained about 30 participants. The memory group showed improved memory performance at 2-month follow-up, whereas the processing speed group showed improved processing speed immediately post-training as well as 2 months later. So interestingly, the processing speed group showed memory improvements, suggesting that there's transfer effects. Even though they were being trained in processing speed, they also showed memory improvement. So these authors concluded that processing speed training may have broader benefits for breast cancer survivors, improving not only processing speed, but also other skills such as memory skills. And this study was also very interesting because it's the closest trial we have that directly compared computerized training to face-to-face therapist-delivered training. And it showed that computerized training had greater benefits. Okay, so what's the take-home message then here? I think we can walk away saying that there are many benefits of computerized training. Some of these would include the ability to standardize and titrate the administration in a systematic manner, which is really important for conducting this kind of research. Also, these programs can be administered remotely, meaning that we can reach individuals who don't live close to providers that they could sit down face-to-face with. We can reach individuals who are all over the world and maybe not somewhere they could drive to work with a therapist. With computerized training, the time burden is reduced relative to working one-on-one with the therapist, and the scheduling can be really flexible in terms of what time of day or time of week you do the computerized training. Further, there's very few, if any, medical contraindications. Probably The only one being that individuals who have photosensitive seizures may need to be careful in doing the program. And as we showed, there's really clear cognitive benefits, particularly for those skills like attention and working memory that are very closely related to the skills that are being trained by the computerized program. However, we should also talk about some of the limitations. Those of these programs that are available for clinical use tend to be relatively expensive and are yet to have insurance coverage. We're hoping that the kind of research we're doing will eventually lead to insurance coverage, but we're not there yet. We're also working to demonstrate that the benefits from these computerized programs can generalize to other cognitive skills, not just the one that they're training with. And we're doing studies just now to look at how well we can maintain those benefits over time and whether there would be a need for occasional booster sessions or just a few sessions sprinkled out over time to help maintain those benefits. So if there are survivors or caregivers who are listening today who are interested in interventions for cognitive problems that they might be experiencing after treatment, I recommend first getting a neuropsychological evaluation. And this is because not all survivors will have the same set of cognitive problems, and you really want to make sure that the interventions you're getting are targeting your specific skills, such as attention or memory or executive function. And a neuropsychologist should be able to provide a number of different types of recommendations. These could include providing a list of compensatory strategies that are specific to your problem. So for example, electronic reminders to offset memory problems, or apps on your phone or your iPad to assist with problems with organization. They should also be able to make medication type recommendations, such as maybe a stimulant medication trial like Adderall or modafinil. They should be able to talk to you about the benefit of therapist-delivered interventions, including things like face-to-face cognitive rehabilitation or cognitive behavioral therapy. And they should be able to talk about computerized training as well, such as the programs that we've reviewed today. And finally, neuropsychologists should be able to provide recommendations with respect to vocational rehabilitation, which can help with assessing job skills or providing job coaching. So here are a list of commercially available computerized cognitive training programs. I am not endorsing these programs beyond the research that I've just reviewed today, but I'm providing them in case you are interested in investigating whether it's something of interest personally for you that would fit with your available time and financial resources. There is a range of costs that are associated with these programs. So for example, Lumosity up here costs about $100 per year, whereas COGMED, the program that we've done a lot of research with, costs closer to $1,200 to cover the entire 25 sessions of training, as well as pre and post evaluations and coaching that's provided remotely by a psychologist that you're paired with. And I think I will wrap up there. This is the disclaimer slide up there that you can see. And I believe I will gain assistance with answering questions from you all.
Yes, thank you, Dr. Conklin. And I apologize for the technical issues that we had in the beginning of this presentation. We'll now take a few questions. We have about 15 minutes. If you have a question you would like to ask, please type and submit it using the question box in the webinar control panel on the right-hand side of your screen. Our first question for you, Dr. Conklin, how can you improve executive functioning, or at least try to keep what you have left using some of these games?
Okay, so it's a really good question. I think executive function problems are something that lots of people experience, cancer survivors, but other individuals just even with typical aging. We can see declines in executive function, including things like working memory. So I reviewed a number of different computer programs that might help with that. COGMED and Lumosity in particular target executive functions. There are also medications that might be something you could discuss with your medical team. Things like stimulant medications can help with attention regulation and focus. And there are also therapists that can work with you. They're sometimes called executive coaches that can help you with exercising these skills, as well as teaching you strategies to help you be more successful with executive skills in your day-to-day life. And finally, we're hoping and doing some research now with aerobic exercise, and it's been shown in some studies that are emerging in non-cancer survivors, but other populations, that individuals who engage in more aerobic exercise may actually, in addition to having cardiac and pulmonary heart and lung benefits, may also have cognitive benefits, specifically in the area of executive function.
Great. Our next question is, could you suggest a reasonable amount of time that someone should devote per day or per week on using these games, and how do you judge if the difficulty level is appropriate?
Okay, another really good question. So typically these programs, these computerized programs, have suggested training about 30 to 45 minutes per day. It might be less in younger children, but for adults, that would be a good amount. And typically they want you to do it with frequent regularity. So the typical recommended dose is to do it 5 times a week. However, the research has shown that if you do it at least 3 times per week, you will still have benefit. Again, so about 30 to 45 minutes a day, at least 3 times per week, with the target dose being about 5 times a week. And then in terms of difficulty, it is really important that whatever program you're using increase in difficulty. If you just get to the point where it's easy, just like with physical exercise, that's no longer going to give you benefit. It needs to keep getting more difficult. COGMED, which is the program I reviewed and which has the most research support across different populations, tries to train you at the level where you're accurate half of the time. So when you're training, you should feel like you're getting about half of the questions or just a little bit more of that right. If you are getting, 80 or 90% of the questions right, then the difficulty needs to be increased.
And at what point in treatment should a patient engage in this intervention?
It's a really good question. I think that is something we are still exploring in our research. The initial studies that were done with longer-term survivors. So in my work, we required individuals to be at least a year out from treatment completion. The reason was that really just to make sure we were targeting individuals who are really experiencing significant problems, and sometimes it takes a while for those problems to emerge. What we found in our research was that individuals who were at least a year out, so anywhere from 1 year out from treatment to 10 years out from treatment, all showed benefits. So even if you're a very long-term survivor, you can still show benefits for these types of cognitive problems with computerized training. We are now in the process of trying to evaluate whether we can do computerized training with people who are on therapy for cancer or have just completed and who are not yet experiencing cognitive problems. The idea being that we would try to prevent the emergence of these cognitive problems rather than try and remediate the problems after they occur. We don't have the results from these trials yet. We're optimistic, but one thing I can tell you is that it's been much more difficult for people to participate in these trials when they're on active therapy or have just completed, just because the amount of other medical appointments they're having, fatigue or feeling ill, or with our children, they may be returning to school or college or jobs, and it's just a lot to take on all at once. So it's certainly more tricky to do that training early, but we are exploring whether that would be beneficial as well.
Great. And do any of these programs, or do you know of any programs that work with people with impaired vision?
That's a really good question. Most of them are visually based because they are provided on computer interfaces, and a lot of the tests are more visual. And the couple that I'm most familiar with, I don't think there would be enough if you had very low vision to get benefit. It would be worth probably clicking on some of those links that I showed on the last slide to see if any of them, outside the ones I reviewed in depth, have more audio presentation. I can tell you, this has not been researched, but just as an example, that we've used in children with low vision, things just like the Simon program, if people remember that game that just has 4 light up buttons on it, where you just have to push them in the order they light up, and it gets more and more difficult and exercises that attention working memory, that there are things like that that we've not yet demonstrated with research have benefit, but are things that you could access cheaply, and that would be possible to do if you had low vision.
Great. And I think this is our last question. Do you know of any ongoing studies for these programs? And if so, how can someone learn about them and possibly participate?
This may be a question I have to do a little research on and follow up later because I know the child literature better. There is a trial going on right now through the Children's Oncology Group. So this would be individuals from 4 to 18 years of age that are receiving radiation therapy for a brain tumor. So if they're still in that early diagnosis and treatment phase, they're being enrolled right at the end of radiation therapy. You could participate. The Children's Oncology Group has sites all over the United States and Canada. So you could find out one of those and look to enroll on that. The only study we have open right now at St. Jude is for children with medulloblastoma who are undergoing treatment here or at one of the institutes doing this trial. I don't know specifically about adult trials that are open right now, but I would be happy to do a little research and get back to this audience with that answer.
Thank you, Dr. Conklin. That's all the time we have for today. Thank you all for joining us, and thanks once again to Dr. Conklin for her wonderful webinar presentation. Besides our free educational webinars, ABTA has a variety of programs available to help connect patients and caregivers with information and resources to help support them in their brain tumor journey, as well as publications and resources for healthcare professionals. For more information, visit ABTA's website at www.abta.org or call the ABTA Care Line at 1-800-886-2282. Let's pause for just a moment to conclude our webinar recording.